there's an additional thin and linear opacity within the apex of the right lung. Notice how this opacity has a thicker portion in the inferior part. We're all familiar with the major and minor fissure normally seen in the right lung in addition to the major fissure on the left side. This is an accessory fissure. This is known as an accessory azygos fissure. In normal embryology, the azygos develops at the lung apex and descends downwards. In some cases, when the azygos does that, it actually invaginates the lung and pulls both the visceral and parietal pleura. And this is what creates an accessory azygos fissure as we see here. Notice that this is the only fissure in the lung that contains 4 layers. By the way, the thickened portion of the lower aspect of this fissure is actually the azygos vein that did not complete its descent to its normal location. For the sake of comparison, this is a normal case showing the usual appearance of the azygos arch as it resides within the right tracheobronchial angle. The azygos arch or the azygos knob has a normal rounded or oval appearance in this location. Now it's easier to understand how such an azygos vein could pull down the visceral and parietal pleura and create an accessory azygos fissure. This is our initial case. So remember, the azygos fissure could have a variable degree of descent from the apex downwards, and that may simulate a nodule. Here's another case with an accessory azygos fissure. The lung that's located medial to the azygos fissure is classically called an azygos lobe. Remember that this is not a true lobe since it does not have its own separate bronchial supply. An important note for senior residents: the azygos lobe may appear opaque, either completely or partially as seen in this case. It is important to remember that such an appearance may be normal or abnormal, and it should always be correlated with the clinical presentation. So we learned from such cases that an accessory azygos fissure may be seen in some patients. The azygos vein may simulate a nodule if it did not completely descend, and that the azygos lobe, which is not a true lobe, may appear normally or abnormally opaque, something that needs to be correlated clinically. Thanks for watching. Today's case is about a small technical detail that you could use when you're doing your cardiac imaging rotation. Since the heart is a rapidly moving structure, it's difficult to image this by CT, and the way we do that is by synchronizing the image to an ECG. The ECG strip is simplified so that the time from one R wave to the second R wave represents one cardiac cycle. And the common language we use in cardiac imaging is to divide the R to R interval from 0 to 100%. It makes sense to expect that the phase of least cardiac motion is the diastolic phase. In particular, the mid-diastolic phase is actually the phase of least cardiac motion where you could see the coronary arteries without haziness. This mid-diastolic phase, the phase of least cardiac motion, corresponds to 75% of the R to R interval. And this study here shows very clearly visualized left-sided coronary arteries without associated motion or a hazy appearance. However, in this patient with a little bit of a higher heart rate, the 75% phase still shows a hazy right coronary artery that's affected by motion artifacts. This appearance could be easily explained by several factors. Remember that when we're talking about systole and diastole, we're talking about ventricular motion. So when you're talking about diastole, that's ventricular diastole at the same time where you may have atrial systole. And noticing that the right coronary artery is the closest to the right atrium, at the time of 75% where you have ventricular diastole, you might have atrial systole. So in some cases, the 75% might show you a very nice left-sided coronary arterial system, but the right coronary artery might be degraded by motion. So one of the tricks that you could use is to image a different phase. And the second phase of least cardiac motion is actually end systole. You could image this end systolic phase by a retrospective or a prospective technique, something that we were not going to discuss in today's clip. So here's the end systolic phase on the same patient. The end systolic phase corresponds to about 45% of the R to R interval. Compared to the 75% R to R interval phase, The right coronary artery on this 45% R2R interval phase demonstrates a very nice appearance. So the first least phase of cardiac motion is mid-diastole at 75% of the R2R interval. The second least phase of cardiac motion is in systole at 45% of the R2R interval. Understanding this, you could use this kind of information to image a right coronary artery that is initially degraded by motion artifacts. Thanks for watching. There are inflammatory changes in the right lower abdominal quadrant in the form of fat stranding and thickening of the lateral conal fascia. One of the most common causes that could lead to such an appearance would be an acute appendicitis, so you have to identify the appendix. Since the appendix may be long and may have a tip that could assume various locations, the easiest thing to look for is the base of the appendix. To identify the base of the appendix, try to look for the terminal ileum as it goes into the cecum at the ileocecal junction. In many cases, the ileocecal junction may contain fat, which is not seen here, and if you see that, that would make identifying the junction easier. Usually the appendix arises beneath the ileocecal junction before you reach the cecal pole, and this is where you see the appendicular base here. One of the observations is this high density at the appendicular base, which could represent an appendicular stone known as an appendicolith. If you follow the appendix itself, you're going to notice that it's dilated, and on a CT scan, dilatation more than 6 millimeter is suggestive of the diagnosis. Another feature that goes with appendicitis is thickening and enhancement of the appendix wall. Notice how the tip of the appendix is located in a more inferior location compared to the appendicular base. With any case of acute appendicitis, you have to make sure you don't have signs of perforation, and you must look for surrounding or remote free air within the abdomen. If you look more closely, you'll notice that there are 1 or 2 small air bubbles adjacent to the appendicular base consistent with a small focal perforation. The next thing to comment on is to make sure you don't have adjacent loculated rim-enhancing fluid consistent with abscess, or in some cases to check for associated mass-like inflammatory changes, something we called phlegmon. This was a basic case showing features of acute appendicitis on a CT scan. Thanks for watching. More cases later. This is a 19-year-old male patient with chest pain. Since I had several requests yesterday to post a basic imaging case, I thought this would be a good case to go with. Part of your chest X-ray analysis should include hidden areas, and one of the hidden areas would be the spine. Even on this frontal chest radiograph, you might have noticed that the shape of the vertebral body is unusual. You don't have that straight end plate appearance. Of course, this is easier to appreciate on the lateral chest radiograph where you have central depressions of the inferior and superior end plates at multiple levels. This appearance is described as H-shaped vertebral bodies, or in some references as a fish mouth appearance. Such an appearance is well known with sickle cell disease, where you have avascular necrosis of the end plates leading to these depressions. We learned from this case that the spine is a hidden area on a frontal chest radiograph, and that you could tell a sickle cell disease patient if you see an H-shaped vertebral appearance. Thanks for watching. More cases later. With any brain CT, you should look for early signs of stroke, especially if the provided history is that of weakness. It should be clearly emphasized that a brain CT may appear normal or near normal, even if the patient has a real acute infarction. This is especially true when the patient has an early presentation. before the edema secondary to infarction starts to appear. So even if the patient has a true infarction, the brain CT may appear normal within the first 6 hours of presentation. In such cases, you have to look for the early signs of infarct, and these include 3 famous signs. The first sign is related to acute thrombus occlusion of the middle cerebral artery. This is the right-sided middle cerebral artery compared to a left-side middle cerebral artery. Notice how this left side MCA has a bright appearance compared to that on the right. This bright appearance is related to an acute thrombus that occludes the vessel, and this sign is known as a hyperdense MCA sign. The second sign is called a vanishing basal ganglia sign, where the basal ganglia on the left side appear ill-defined compared to that on the right. On this case, due to a noisy image, it is not very appreciable that the basal ganglia appear differently. The third acute sign is related to this region here. Before we start, we need to know that this fissure here is called the Sylvian fissure that contains this dark CSF. We know that the outer brain is called cortex, the inner brain is called white matter. The cortex outlining this region is called the insular ribbon. The appearance of the insular ribbon is called an insular ribbon sign, the third sign of acute stroke on a CT scan of the brain. The ribbon sign is well appreciated on the left side, where you cannot differentiate between the cortex and the white matter. Remember that with infarction you have associated edema. Edema on a CT brain may appear as hypodensity or signs of mass effect. Knowing that, notice how the right-sided normal insular ribbon has very clearly seen sulci and gyri. By the sulci, we mean these interdigitations of CSF between the brain tissue, very similar to what you see here. Now compare this normal side to the abnormal side. Where you have the early signs of infarct, you lose these sulci. Edema related to infarction in any part of the brain would give you what we call sulcal effacement, a sign of mass effect. We saw the initial CT. This is a CT follow-up performed about 3 days later. On the follow-up CT, it's clear that the patient has a very large area of cytotoxic edema that's affecting the left MCA region. It's even more clear on this CT how you lose the insular ribbon compared to the right side. Not only that, one of the important pieces of information you should provide in the report is the presence or absence of these bright spots within the infarct. This is a known complication of infarctions, especially large ones, known as hemorrhagic transformation of an infarct, which is an anticoagulation contraindication. Several things from this case. The first most important piece of information is that even with acute strokes within the first 6 hours, you might have a normal appearing CT. The thing we learned today is to look for signs of acute infarction on a CT scan, including a hyperdense MCA sign, an insular ribbon sign, and vanishing basal ganglia. The third thing we learned is to do a follow-up scan on such patients, and don't be surprised if you see a clear-cut infarction or hemorrhagic transformation. Thank you for watching. Please remember that we would always appreciate your feedback and comments on the cases that we're showing, and see you later.